Hi everyone, welcome to another Rafael Medina subspecialty VMR. My name is Hui Tin, and tonight's session we will be focusing on infectious disease. So we have two amazing clinicians from UCSF, University of California, San Francisco. So our case discussant is actually not a stranger to our community. She's been here before as our case discussant and also presenting a case. So she is Dr. Natasha Spottiswoode, and she's infectious disease fellow at UCSF. So Dr. Natasha, would you like to unmute yourself, say hello to everyone, and just remind us why did you choose infectious disease?
Hello, everyone. Thanks so much for joining and appreciate those on the East Coast for whom it's pretty late. So I chose infectious disease for multiple reasons, and I'm going to try not to repeat what I said last time. But it's a fantastic combination of getting to be a mystery solver, an advocate, and someone who gets to play a role in some of the major crises that the world faces. Infectious disease is an incredibly cool field because it's always changing. As we have more immunocompromised patients, we discover more viruses and more fungi and more parasites that affect them. And as the world changes and zoonotic diseases emerge, we are here to respond to them. It's a really cool field. Would recommend.
Oh my God, thank you so much for sharing that with us. So as our case presenter, we have Dr. Cyrus Ghaznavi. He is internal medicine resident at UCSF. So Dr. Cyrus, would you like to unmute yourself, say hello to everyone, and also tell us why, I know that you have a passion about infectious disease. So tell us a little bit more about that.
Hi, everyone. Thank you so much for joining today. My name is Cyrus Ghaznavi. I'm currently an intern at UCSF in their categorical internal medicine program. And I, too, am a huge fan of infectious diseases. And for me, it's a lot of the same reasons. You really get to go hunting for dragons in ID, a lot of great differentials. You have the differential of the disease, you have the differential of the organism, you have the antimicrobial differential, and you really get to put your thinking cap on and dig through a lot of phenomenal data in the social history and the exposure history, and you really just get to know the person as a holistic patient, and that's what I love about ID.
Oh my God, I think we have like two detective tonight. So I'm so excited and so happy to have you both. So I know that we're gonna learn a lot from this case. Also tonight we have two of our academy member joining us. So we have Gia, who's gonna help us describing the case, and also we have Parisa, who's gonna do the teaching points. So thank you so much both for helping out. So whenever you're ready, Gia, yeah, thank you so much. And Dr. Cyrus, you can, whenever you're ready, you can start with the first aliquot.
All right. We have a female in her 70s with a past medical history notable for ESRD on hemodialysis, heart failure with recovered ejection fraction now at 55%, AFib, pancytopenia of unknown origin, hypothyroidism, and chronic hepatitis B infection, presenting with generalized weakness and altered mental status ongoing for 2 weeks.
Cyrus, would you like to give us more information? Or Natasha, do you want to hear a little bit more, or do you think that you want to start with this? Because a lot of information, speaking like immunosuppressed patients, so we kind of have a lot of things going on. Do you want to start sharing your
Sure.
thoughts, or you want more information? It's up to you.
Maybe I'll be super quick about thoughts. So when I first hear about a patient, I want to think, are they immunosuppressed or are they immunocompetent? If they are immunosuppressed, how are they immunosuppressed? This person, I've heard two ways in which they could be immunosuppressed. One, they have ESRD on HD, which does provide some immunosuppression and also a portal of entry to their bloodstream. And also they have pancytopenia, which is interesting. And we don't know how bad it is in which cell lines are down, but that could potentially be immunocompromising in multiple different dimensions. Weakness and AMS are very interesting complaints, as is the fact that they've been going on for 2 weeks, but I will not get too ahead of myself and pause there. I would like more data.
Great. Well, I'm happy to tell you a little bit about the HPI. And I actually did not admit this patient. And so this is all largely from my own personal chart review. But basically what happened was that this patient she has a daughter who's very involved in her life. And her daughter was concerned because over the last 2 weeks, she noticed that her mother, normally a perfectly functional individual, was having some trouble standing without assistance and was acting just a little bit more confused than usual. And that was manifesting not only in the way that she spoke, but she was taking some of her medications wrong, when prior to that, she was on top of things, more or less. She was usually able to walk short distances, even climb stairs, but was having a lot of trouble doing that. And she was also known as being a pretty thoughtful and articulate person, but was beginning to mix up words, and her short-term memory was getting notably worse. Talking to the patient on intake, she was noting some right lateral neck pain that had been going on for several weeks, but her range of motion was intact. She was not having any fevers, no shortness of breath, no diarrhea, constipation, and just generally said that she was feeling overall very weak. We can also do some of the medications and family and social history if you'd like. Great. So largely her medications were not too remarkable, but she was on apixaban for the AFib. She was on Lasix for the heart failure, gabapentin, levothyroxine, metoprolol succinate, midodrine for occasional episodes of hypotension at dialysis, and sevelamer. Her past medical history was as described, and as Natasha noted, the pancytopenia. There's no information on this pancytopenia in her chart. She has no known allergies. The only notable family history is schizophrenia in her son. And her social history, I'm happy to go into now or wait if you'd like, Natasha.
I think since we're there, let's have the social history. I also am interested that she is not on any medications for the hepatitis B.
I'm sorry, she's on tenofovir. She's on TAF.
Oh, she's not. Okay.
Her social history, she is originally from Indonesia, has been living in the United States for 42 years. Her husband has passed away. She is not sexually active, and she has 2 children who are largely involved in her life. No alcohol, drug use of any kind, or any tobacco. She lives in SF with her son.
So, Natasha, let's pause here for a minute. I know there's a lot of detail, a lot of information. So, at this point of the presentation, if you can maybe, because I know that in infectious disease, it's usually very helpful to put like the pathogen or think about the pathogen different bucket. So in this case, with all the information given, what type of pathogen come to your mind? Is it something viral, fungi, or bacterial that you're thinking?
For sure. Yeah, so thinking about different pathogen buckets, I'm actually going to take a step back before I get there and think about which organ system is being implicated here. When you talk about a patient who is confused and who is altered and weak, I immediately jump to a CNS infection, which could be a meningitis or encephalitis. And it sounds to me here more encephalitic than meningitic. So that's one bucket. Another bucket is that another organ system is being affected that in turn affects her mental status. So the obvious association here, the overlap, is that she might have new onset cirrhosis from HBV, which is then causing a hepatic encephalopathy. But we haven't heard anything else that goes for that. She's not jaundiced, etc. So I suspect that that's less likely, and I'm going to concentrate on the CNS. So thinking through CNS infections, we start with typical bacteria. So your strep pneumo, your staph, those tend to be an unsubtle meningitic picture. They're also quite rare, which is not to rule it out, but it is to say that those people tend to have the classic signs and symptoms of meningitis that we think about, that we're taught, the Koenig's and the Brzezinski's sign, and she doesn't seem to have any of that. Then we think about the atypical bacteria. So I think about Listeria with the right exposures. And I think about other sort of more remote bacteria. I think about syphilis in almost every patient, although it doesn't sound as though she's got risk factors. And then I start thinking about the mycobacteria. If someone has emigrated from a TB endemic country as Indonesia is, then TB is always on my differential. TB is kind of always on my differential. And in this case, it's not a terrible history, especially if she's more immunosuppressed now. TB can reactivate. Fungi, endemic fungi in California include valley fever or cocci, rarely Cryptococcus, including Cryptococcus neoformans if she's immunosuppressed enough. Cryptococcus gattii is a rare but horrible fungus that we have here, which can sometimes turn up even in immunocompetent patients, much less commonly histo. And then going into the other bugs, viruses do affect people who are immunocompromised. I think about our herpes viruses, especially our HSV1 and 2. Let's see, parasites, I can't make as compelling a case for yet, although they're remaining in the back burner. So I'm thinking TB, thinking viruses, I'm less thinking conventional bacteria.
Thank you so much. And I love how you make a step back and think about the organs before giving us all the information about like the different pathogens you were thinking. So Cyrus, back to you.
All right, so a little bit more on the course of this patient. When she was in the ED, her BP was 108/68, a heart rate of 95. Her temperature was 36.9, and she was satting 97% on room air. Overall, on physical exam, she appeared generally weak and altered ANO ×2, but the remainder of her exam was pretty unremarkable. There was no jaundice, as you mentioned before. However, while she was in the ED, she was suddenly RVRing to about 170, and she suddenly became hypotensive, and pressors were initiated. She was swiftly escorted up to the ICU. Happy to give some initial labs. That would be helpful. So, at the time, white count was 5.3, hemoglobin was 8.1, down from a baseline of 9s to 10s, and her platelets were 118. Her BMP was with a sodium of 135, a K of 5, a chloride of 94, a bicarb of 29, a BUN of 45, a creatinine of 5.85, and a calcium of 9.6. Finally, her LFTs with an ALP of 24, an ALP of 87, an ALT of 24, and an AST of 66, with a slightly elevated total bilirubin of 1.8. We had a chest X-ray done early on as well, which showed an enlarged cardiac silhouette, but otherwise clear lungs. And we'll stop there to talk about ICU workup.
So Natasha, what do you think? There is some information about the lab, about the vitals. Is there anything that caught your attention?
She sounds quite sick. And I'm very glad that she's in the ICU getting the care that she needs at this stage. I think things that catch my attention is that she's ANO ×2, which is not normal for her by the sounds of it. And you have the advantage of a committed family member who can tell you that this is not her normal. I also think that these vital signs are consistent with sepsis. She is showing signs that she's responding to an overwhelming, or to not yet overwhelming, but to a significant metabolic strain. Her heart has gone into RVR. We know that she has a prior history of AFib. People susceptible will often go into RVR when faced with sepsis. Her pancytopenia, I'd like a differential on that white count, but this is not as bad as I might have expected. I was worried that she had profound pancytopenia, which would change my pretest probability for some infections. But in terms of what I'm looking for now, I would really like blood cultures for sure. And I anticipate that I will be asking for an LP after we get a CT head to rule out large space occupying lesions.
All right, I can pull up the exact differential for that CBC, but I know for a fact that it was normal. If you like specific numbers, happy to report those. And then for
Normal is good enough for me.
okay, perfect. And the head CT was in fact done, and it showed no acute intracranial abnormality, no space occupying lesions of any kind. Would we like more ICU lab data at this time?
We would. We are also curious about whether an LP was done in the ED or ICU.
Absolutely. So we did in fact get an LP, and that LP basic labs were as follows. The CSF glucose was 59. The CSF protein was 26. There was 1 red and 0 nucleated cells. While she was in the ICU, she was there for 9 days or so, was on pressors, getting CRRT instead of her normal intermittent hemodialysis while she couldn't handle the drops in her blood pressure. She was getting a lot of midodrine as well. And during those 9 days, an extensive initial workup was performed, and I'll summarize some of the highlights here. So we started with an RPR, blood cultures, those came back negative, and then several of the fungal studies and other studies that were in your differential before were also performed. A COX-C antibody came back negative, as did a galactomannan and a cryptoantigen on the serum. Her HIV was negative. A histo antibody was negative. However, a histoplasmosis antigen was slightly positive, just above the normal threshold. She got multiple AFB cultures of her sputum, which were no growth to date, and did not have anything on smear, and their MTB PCRs were also negative twice. She had an EBV, HSV, and VZV of her serums, which came back negative, and HSV, VZV in her CSF also came back negative. Additional CSF studies included a fungal culture and bacterial culture, which also were not growing anything at this point, now about 8 days after the fact. She was also worked up for some non-infectious etiologies, and a ceruloplasmin ordered out of concern for Wilson's came back within normal limits, and an autoimmune encephalitis panel also came back normal. That's what we have for now.
So Natasha, actually, I'm going to ask you a very easy question now for our early learners. So when we talk about LP lumbar puncture, what do you expect to see when it's viral causes, fungal, or bacterial causes? Would you like to summarize that for us?
Yeah, of course. So I think that I'd like to make a brief point about bacterial meningitis. As an infectious disease physician now for 3 years, I have seen 2 cases of community-acquired bacterial meningitis in a previously healthy patient. And both of them were extraordinarily unsubtle. This is a disease that we should always think about because it's so morbid, but it is mercifully quite rare. So in conventional bacterial meningitis, especially in a host whose immune system is working well, you should have elevated protein, low glucose, high nucleated cells, and usually they should be neutrophil predominant. For mycobacteria, you should also have a high protein, low glucose, and it may be neutrophil predominant, but it's more likely to be lymphocyte predominant. Viruses can vary. And if you have findings where you're looking at them and saying, that could be normal, it's probably a virus if it's an infectious CSF etiology. But classically, high protein, normal to slightly low glucose, and the white blood cell count should be non-neutrophil predominant, usually lymphocyte predominant. So that's how I tend to break it down. So this is a surprisingly normal LP, which does not entirely rule out an infectious cause of her altered mental status, or at least not a CSF. It does not rule out a CSF infection or CNS infection. But it does take to me bacteria and to some degree TB and fungi and put them further down the list.
Great. That's a great summary. So another question, Natasha, when you see all this data of all the results, most of them are negative. Is that helping you to reach the diagnosis, or is not at all? How do you feel about this lab work?
Yeah, so I think some of these tests have, so I tend to find it very helpful to break down tests by their negative predictive value, if they're negative, and also their positive predictive value, because we do have a positive. So thinking first about some great tests, cryptococcal antigen from the serum is a fabulous test. It has really great negative predictive value. So I'm very happy to see a negative CRAG. Other tests that have a less good negative predictive value, galactomannan for one, beta-D-glucan similarly, I would say neither of them being negative rules out a fungal infection for me. And especially in the case of beta-D-glucan, positive does not mean they definitely have a fungal infection either. In terms of some interesting tests that we do have, I would say that I'm particularly interested in the histoplasma antibody. And I would be curious to see how slightly elevated it is. That's not a normal finding. It could indicate the presence of another fungus, such as blasto, although we certainly do not get much of that here. I see that you've corrected to histoplasma antigen, my apologies. Histoplasma can also cause pancytopenia by infiltrating the bone marrow, and it tends to cause a critical illness syndrome that is specifically associated with an extremely high ferritin. So histoplasma is not the first thing I would think about, but it certainly is on my list of potential causes of this syndrome. I would like to say that I'm extremely happy that no one suggested ordering a quantiferon gold to rule out active tuberculosis, because quantiferon gold is a very bad test for active tuberculosis, and I often see that ordered. It is an okay test for latent tuberculosis. And then the last test that I'll comment on here is that EBV is a herpes virus that can reactivate in critically ill patients for any reason. So I'm very glad it was negative, because even if it were positive, I would be less inclined to consider it causative here.
Oh, what amazing lab interpretation. So yes, that was great learning the negative predictive value. I think that's the first time I'm listening to that. So yeah, so I cannot wait to hear more from Cyrus. Yeah, go ahead.
Yeah, I do have another aliquot of information, actually still from the ICU. There was a lot of stuff done there. And so 2 days after she was admitted to the ICU, they got a CT abdomen pelvis on the hunt for a source. And they saw retroperitoneal and right pelvic lymphadenopathy. And in particular, they saw this on the pelvic sidewall, in the right common iliac nodes, and in the left para-aortic node. And the node in the right common iliac area seemed to be necrotic. And that was noted on the radiology reading. It was hypodense and necrotic appearing. Furthermore, on day 6, while still in the ICU, she was noticed to have some left-sided nasolabial facial flattening, and it was asymmetric. And so they got a CT head stroke protocol, which came back unremarkable. And they followed that up with an MR brain. And the MR brain showed new punctate infarcts within the bilateral cerebral hemispheres throughout the white matter in no particular distribution, as well as some remote microhemorrhages in the deep cerebellar white matter and decreased perfusion to the posterior circulation, with no obvious differential given by the radiologists.
Interesting. Should I comment?
Yeah, Natasha, do you have any comment about the CT? I know there's a lot of information. What are you thinking now? I'm curious.
Well, I think we've gotten two really important pieces of information. One of which is that I'm really glad they did these scans. I'm glad they did the CT and the MRI because those are good ideas when looking for a source in a patient who is very sick and you don't know why. So we firstly learned that this patient has generalized lymphadenopathy that is concentrated in the sort of pelvic and retroperitoneal region generally. And we have also learned that this person has new punctate infarcts on that MRI. And this points me towards especially the MRI findings, point me towards a possible vascular process, either an infection that is taking place as part of the vasculature or something that is happening endovascularly, such as endocarditis. This patient is at risk for endocarditis, both because she has a line in place, and she also may be at risk for culture negative endocarditis, which is a very interesting and not particularly rare phenomenon. Thinking about the endocarditis bucket, I would definitely want to get an echocardiogram starting with a TTE. And I would think about sending some serologies depending on additional risk factors, which we may not have heard about yet, but which I would ask about. Speaking of sort of the infectious endocarditis bucket that is culture negative, this is often because the patient has received antibiotics before blood cultures were drawn, if it's conventional bacteria, or it's a bug that doesn't culture very well. And that bucket includes fungi and our zoonotic friends. Common in the San Francisco area is Bartonella. With the right exposures, people also can have Coxiella, Brucella, all of which tend to have typical exposure routes. So I want an echo. I might ask a few more questions about animal exposure. And I think I would start thinking about unbiased diagnostics such as metagenomic sequencing if that were available at my institution, which it is.
Thank you so much, Natasha, for bearing with this deluge of information, which is one of the reasons why I love this case so much. So there was, in fact, an echo done, and it did not show anything suspicious for a cause of endocarditis in our patient. And speaking to the daughter, there were no strange animal contacts, not anything of the kind that would get an ID physician particularly excited. And now that you've bared with me for 9 long days in the ICU, finally I meet the patient, and she is downgraded to the floor. And so I would like to just do a quick reset and let you know what I saw the first day I met this patient. On physical exam, she looked very ill, and she was very, very delirious, writhing, screaming in pain, in mittens. She was tachycardic with an irregular rhythm. Otherwise, lung sounds were clear, and abdominal exam was benign. And on neuroexam, she was frankly disoriented, now ANO times 0, and moving all extremities spontaneously. And at this point, what was really most striking on her exam, and that I personally will never forget, is that she would only speak in her native language, and not even a language her daughter understood. So she had completely reverted to native language and was not amenable to being spoken to in any of the other multitude of languages that she normally would be able to speak. Repeating her labs, her CBC was fairly stable. White count was still in the 5s. Her hemoglobin was now 7.5, and her platelets were hovering right at 100. And her BMP was notable only for one change, and that was that now her calcium was elevated at 12.3. Furthermore, just to give an additional piece of information for us to chew on, as if we didn't have enough already, is that 2 days after I met her, the AFB cultures that were obtained on day 4 and that had been no growth to date were now growing a non-tuberculous Mycobacteria fortuitum.
Which site were those cultures from, Cyrus?
Those were the sputum cultures. AFB blood
Interesting.
cultures were sent soon afterwards.
Yes, great. I was going to ask for that. Interesting. So we have new hypercalcemia, which might point towards a granulomatous process, which would fit with the retroperitoneal lymph nodes. I also want to step out of diagnostic moment for just 1 second and also say that it sounds as though this patient was suffering immensely. I really cannot imagine how distressing it would be to not be able to understand the people around me and to be confused and delirious in the hospital. So I am sure that you were there for the patient and her family, but just to acknowledge sort of the human side of this. But certainly this constellation that you're giving me with the finding of fortuitum makes me interested and concerned about a potential disseminated non-tuberculous mycobacterial infection. I would like blood cultures, AFB blood cultures, and I would also very much like to discuss a biopsy of these lymph nodes if they have not been discussed already. In addition, I would like to ask if the LP was sent for AFB cultures. You haven't mentioned that, and it should have been done given the concern for TB meningitis.
Phenomenal questions, and I'm so glad you asked. So, addressing your last question first, the first LP that was done in the ICU did not have sufficient quantity to send for additional testing, including CSF AFB cultures, and it was triaged out of the testing that they wanted to do. They also wanted to send a CSF MTB PCR and a CSF metagenomic testing, but none of those three were sent. And then, sorry, Natasha, could you remind me the first question you asked just now?
No worries. I basically wanted AFB from the blood and to ask if anyone had talked about biopsying the nodules.
Excellent.
To be explicit, I want biopsy cultures for fungus, MTB, for fungus, AFB, beg pardon, and bacteria. And I would also like to send them for what's called universal PCR for non-tuberculous mycobacteria, TB, and fungi. And I can talk about the distinction between metagenomic sequencing and universal PCR if that's helpful.
Awesome. We, in fact, did get a biopsy of that necrotic lymph node, an FNA, a fine needle aspiration, and that fine needle aspiration was negative on pathology for any and all stains, including the fungal stains and the stains for AFB. We sent the FNA for culture, for all the cultures you just recommended, and we sent it out for send-out testing with, for example, UPCR and MTB PCR, and all cultures and all send-out testing actually came back completely negative. And to note, on biopsy, for the pathology read, the only note was that it was incredibly hypocellular and necrotic.
It sounds as though that might be a bit of a suboptimal specimen. And so I wonder if we're going to end up in the world of repeat biopsy, but maybe it would be helpful if I briefly talk about metagenomic sequencing versus what's called universal PCR. Cool, I will do that. Metagenomic sequencing and universal PCR are very different approaches to the problem of how you identify an organism if you cannot culture it. So taking metagenomic sequencing first, that is a relatively new approach. Currently, metagenomic sequencing of plasma is offered by a commercial company called Carius, which many hospitals contract with. CSF metagenomic sequencing is actually rather specific to UCSF at the moment and is also very cool. But the idea of metagenomic sequencing is that you sequence the entirety, all the sequences of a body sample, such as plasma or CSF, and then you computationally subtract out the sequences that align to human. And what you are left with is non-human sequences. Now, those can be contaminants. You can get contaminants. They can be commensals, like low-level CMV activation in very, very sick patients. But hopefully, it will give you the pathogen or the pathogens that you're looking for. Now, universal PCR, which I think is a little bit of a misnomer, and I prefer broad-range PCR, is looking at a class of pathogens with a conserved region. So to take bacteria for an example, you take the ribosomal genome, part of the bacterial genome, amplify it up. So you amplify up any bacteria present, and then you sequence it and look at the variable region. So it will tell you if there is a bacteria, what is it? This works great for bacteria. It works for viruses. It works for mycobacteria. I misspoke for a second there. Sorry, it works for bacteria, fungi, and mycobacteria. It does not work for viruses because they have no conserved regions. So you can't use it for viruses. In this case, I would be sending metagenomic sequencing from both plasma and CSF. And we've sent a universal PCR, so-called, from the fine needle aspirate. They're very, very dependent on the goodness of the sample and the chance that the sample has bugs in it. So if we end up completely stuck, we may need to talk about a repeat biopsy. But I'm curious to know if there was metagenomics.
Yeah, so Natasha, great explanation about the two different genomic sequencing and also universal PCR. So would you mind to tell us when will you consider to order them? What are the criteria to order those tests?
Oh, I'm really glad you asked. They have very different use cases. So starting with metagenomics from the plasma, we tend to order under sort of one of several situations. In general, you want to order it if you think that you have a patient who has an infection which you are unable to detect by usual means. So the buckets I tend to think about where we often send it: febrile neutropenia, culture negative endocarditis, highly immunocompromised patients with pulmonary lesions, and patients who have a clear source of infection that cannot be sampled. So a patient with a CNS infection who, for safety reasons, you can't get an LP, an intra-abdominal infection. The last bucket where we consider sending it is true fever of unknown origin. Now, those are mostly my opinions, and I'd say that we as a community are still working out how best to use it. For the CSF, I would argue that we should use metagenomics quite a lot, because most unknown CSF infections are bugs that don't culture. So that includes viruses, it includes mycobacteria, it includes fungi. All of those are really, really bad at culturing in the lab. So if you're not dealing with a conventional bacterial CSF infection, or the patient doesn't have clear HSV or VZV, I send metagenomics. In terms of universal PCR, that is available from multiple tissue types, but not from blood and not from CSF. At least for us at our institution, we do not send it from CSF. But I tend to send it on a biopsy specimen where I think there's a high concentration of bugs and that they're not going to culture. So again, enriching for our mycobacteria, our fungi, and our sort of hard to culture bacteria.
Wow, that is very interesting. Thank you so much for clarifying when we should consider to request for those tests. So Cyrus, we want to hear more. Back to you.
All right, I have more to tell you. So at this point, patient is interestingly, without any sort of treatment, getting back some of her cognitive function, but still not really able to mobilize. And every once in a while, she is able to speak in one of her other languages. And so given the largely negative infectious workup up until this point, we have been trying to entertain other etiologies, including, for example, oncologic workup, but her SPEP and her UPEP are not coming back revealing. We're entertaining the idea of intravascular lymphoma, a very rare form of lymphoma, getting dermatology on board, infectious diseases already on board. So far, we're holding all sorts of antimicrobials. However, after about 20 days since she was admitted, her mental status all of a sudden got a lot worse. And so we got a new MRI. And this new MRI showed everything we saw the first time, but the main read was new embolic shower phenomenon with no particular pattern of distribution. So it had been additional embolic shower since she was last imaged. She was also getting intermittently hypoxic and was requiring more oxygen than usual. So we got a CT chest on her. We had actually gotten a CT chest on her long before that showed what the chest x-ray showed, which was nothing remarkable. But this new CT chest showed new and increased diffuse bilateral randomly distributed pulmonary nodules in a miliary or hematogenous spreading pattern.
How good was the TTE?
The TTE was good.
Okay, I think at this point we need to go back to a couple of things. So this is definitely something happening intravascularly. I agree. Although intravascular lymphoma is not something I probably would have reached for. I hope we have metagenomics of plasma by this point. I would at this point send the serologies for reasons to have culture negative endocarditis, even if she didn't have classic risk factors. I have seen memorable cases of Bartonella in people in San Francisco who did not have any of the classic risk factors and sort of swore blind that they had never even met a cat, let alone been scratched by one. But I would send those serologies now. I would send the metagenomics now. I would repeat a TTE now and strongly consider a TEE. And also, I am highly curious to know what the AFB blood cultures have shown, because the two signals we've gotten so far are one, a histoplasma antigen, and two, the growth of a mycobacterium that should not be growing from her lungs. So I am curious. So chasing both of those down, I want my molecular tests. I'd be thinking about a second biopsy. I'd be thinking about cardiac imaging. I'd probably think about repeating sputum cultures to find out if she is growing more M. fortuitum. But so far, I want more signal pointing me towards either the histo or the M. fortuitum, because this process is getting worse. And so we really need to find out what's going on.
It's as if you were there. So I can say that no culture of any culture medium is so far growing anything. Bacterial, fungal, AFB, nothing is growing on those cultures. We did get serum metagenomic testing, which has at this point come back entirely negative. We have not gotten new CSF from her at this point. We saw that embolic shower and like you were concerned for intravascular phenomenon, and so we wanted to get a TEE. In fact, at this point, we're now almost 30 days into her course, and things are getting very confusing. And as this really full whiteboard shows you, there's a lot of data, and things are getting a little bit overwhelming to process. And so we decided to take a hard reset at this point, and we recreated our plan, said let's not anchor on any one thing. Let's think about other etiologies. And so in addition to getting a TEE, at this point, we are now considering a repeat lumbar puncture, which up until now, our neurology colleagues had been advising against, but were now agreeable to. We wanted to get a new biopsy of that lymph node, and instead of an FNA, we wanted to get a core biopsy of that lymph node. We were also considering a PET scan to rule out any sort of occult malignancy, as in discussion with our oncology and neurology colleagues, there was concern for a metastatic process going on in her brain. I'm happy to start with any of these, but I'll try to actually tell you this in the order they happened, because the main complicating case feature here was that she was so delirious that none of these could happen in an easy way, and she had to undergo anesthesia for each and every one of them, which made what would have normally taken 3 days take about 2 weeks. The first thing that happened was actually the TEE, and the TEE came back completely clean, without any vegetation or any thrombus, and her ejection fraction and everything else from a cardiologic standpoint was the same as before. Her PET scan was next, and it came back with no evidence of malignancy head to toe anywhere. She then got an MRI under anesthesia with the LP, she got the LP under anesthesia, and those studies that you wanted were all sent off. And this time, there were 5 nucleated cells in the CSF, otherwise largely unchanged. Finally, we got a core biopsy of that lymph node. And when that core biopsy was sent to pathology, it came back positive for AFB organisms on the initial stain.
What were the nucleated cells in the CSF?
Let me see if I can pull that up for you. But my
No worries.
recollection was that they were lymphocytes.
I also would like to empathize. I'm not so far out of intern year that I don't remember how hard it is to arrange for these different studies under anesthesia. And so just to acknowledge the work that goes into getting these studies so that the patient can get a diagnosis and we can have a fascinating case. But I know it's not easy, especially with a delirious patient. But to go back to this new data, I find this very, very suggestive of a diagnosis. Specifically, the combination of elevated calcium, AFB in the core biopsy. I'm glad you guys got a core biopsy. A changing LP, the worsening miliary pattern, and the new finding of nucleated cells in the CSF makes me very concerned for a disseminated mycobacterial process. And I would like to withhold judgment for now about whether it is TB or a non-tuberculous mycobacteria.
A prudent decision, perhaps. Yes, they were largely lymphocytes and neutrophils in the CSF. We had one red again, and then our glucose was actually low at 29 upon that repeat CSF, and our protein was 61 within normal limits. So what ended up happening next was a flurry of things. But at this point, the AFB was staining positive. And you had asked before, Natasha, can we get some more sputum on this patient? And oh, how I tried to get more sputum on this patient every day for 2 weeks straight. But respiratory therapy was unable to get any sputum and she was not able to cooperate. And so for 2 weeks, the only sputums we had were the two that were drawn in the ICU that were only growing non-tuberculous mycobacteria and no tuberculous mycobacteria. So we're now at this point, 30 days in, the lymph node core biopsy comes back positive for AFB, and we have involved the Department of Health, and they have also recommended empiric treatment for mycobacterial infection, in particular, waiting to see if that CSF metagenomic sequencing comes back with anything. But then she gets hypotensive again and immediately goes back to the ICU for CRRT, and her care kind of resets. Luckily, some new lab data comes back pretty soon afterwards, which show a metagenomic sequencing in her CSF positive for Mycobacterium tuberculosis.
I was going to say this is sounding so much more like TB than anything else. Also, I completely acknowledge. I am very curious to know, during the 10 days that you were trying to get sputum cultures on her, what isolation was she on?
She was on no isolation while off her, while the two sputums were the only sputums we had that were negative on smear, she was off isolation. And every time we would order a new sputum, she would briefly go back on isolation. And then in consultation with infection control, she would come back off as she didn't meet criteria. They finally were able to get new sputums on her at around 31 days. And these new sputums all consistently grew a lot of TB very quickly.
That makes sense, unfortunately. This is actually a good story for TB. Talking about why, can I say why it fits TB well? This is a patient from an endemic area. We take care of a lot of patients in San Francisco who have been born in countries where TB is much more common than the United States. And often these patients have reactivation upon getting older and developing one or more kinds of immunocompromise. In this case, this patient had ESRD, that is a form of immunocompromise, and TB reactivated. It's a big risk factor. The other things that fit really well with TB are the relatively subtle presentation. I have a colleague, Michael Wilson, who is our CSF, the man who developed CSF metagenomics, and someone I look up to immensely. He has actually worked a lot on trying to specifically diagnose CNS TB because it is one of the hardest diagnoses to make. It usually does not grow. AFB cultures take a great deal of volume, and so they're often missed out from the first LP. That also fits the story rather well. The other things that fit very well are the presence of a miliary pattern on on her lungs, and it is relatively uncommon to get disseminated fortuitum. And it's also fairly uncommon. I've not seen Mycobacteria fortuitum causing sepsis, whereas tuberculosis can absolutely cause sepsis. It's not to say it's impossible, but it fits TB a lot better. So I am guessing that the final diagnosis was disseminated TB, including TB meningitis and retroperitoneal lymphadenopathy. Is that fair?
That is more than fair. That is correct. I will only add the caveat that the first time we saw the Mycobacterium fortuitum, this was pretty early in the course, just a couple weeks in. It was officially deemed that this was not the contributing factor and that it was just a commensal, and that by the time the TB diagnosis was made, there was enough uncertainty in the case to go ahead and consider that to possibly be pathogenic in addition to the Mycobacterium tuberculosis.
What was made in the end of the slightly positive fungal antigen? Was that thought to be non-specific?
It was
I
thought
would
to be
non-specific.
It was thought to be non-specific, but if I could just draw our attention to one of my favorite parts of this case, it's one lab in particular, and it was the calcium. We were fixated on this calcium. All of a sudden, it was so clearly high. I went through the full hypercalcemia workup, the workup that I thought only appeared in textbooks, but apparently it's real. The storage form of vitamin D was elevated. The PTHrP was low. The ACE was low. It was a classic example of possibly granulomatous hypercalcemia. And we were concerned because histoplasmosis can do that too. And so we were really engaging in conversation of, do we think that this is a signal for TB or histoplasmosis? That vitamin D was pretty early. It was long before we had the TB diagnosis clinched. But we were really thinking about TB and histoplasma the whole time. But clinching that diagnosis, like you said, for TB meningitis is so challenging. And unfortunately for her, the challenge wouldn't end there. Because of her Hep B and her cirrhosis, she would be recalcitrant to a lot of the treatment as well, and would need a lot of effort and thought into what kind of TB treatment she could tolerate.
I didn't realize she had cirrhosis. Do you mean ESRD?
Excuse me, the Hep B, sorry.
Okay.
So her background Hep B, which was thought at some point to possibly be in the early stages of cirrhosis.
Okay, got it. Yeah, treating her is going to be a whole other bucket, which we can definitely talk about, but it's certainly non-straightforward, which is actually generally true of the patients that we see. Taking a step back, I want to really appreciate your hypercalcemia workup. I have been in infectious disease too long because to me, hypercalcemia is granulomatous disease until proven otherwise. And I do know that there are other causes. I just don't see them as often. So to me, TB is hypercalcemia is usually TB or other granulomatous diseases until I discover otherwise. Let's see. Treatment for her will be challenging. A lot of the patients we diagnosed with TB in San Francisco are the patients who emigrated from endemic areas decades ago and became immunocompromised. So that population is super enriched for patients with transplants, bone marrow transplants, solid organ transplants, other medical comorbidities such as cirrhosis, such as end-stage renal disease on dialysis. And so treating TB, which is never an easy proposition at the best of times, is frequently very, very challenging. But I really would like to just appreciate the diagnostic clarity and the clear care that you and your team gave this patient to get to this point.
Wow. So speaking of taking care of the patient, so Cyrus, oh my God, that was an amazing presentation. And oh my God, it's amazing case. And that is just for your intern year. This is, oh my God, I think it's incredible. So would you like to share with us how your experience taking care of this patient?
Absolutely would. This is a patient I will not soon forget. And thank you so much, Natasha, for your thoughtful comments and your excellent sort of dissection of the case and the clinical reasoning that was going on here. It really was a master class. I just want to share 3 thoughts and keep this brief. But first, I want to emphasize what we all have heard so many times, that TB is the great mimicker. We saw evidence of vascular involvement. We were thinking cancer. At some point were thinking autoimmune. the imaging was all over the place, and finally it ended up being TB. It's such a gotcha moment at the end that yes, it is a necessary reminder, a splash of water to the face, that TB can really look like anything and it should be considered very early. And in this case it was, but logistically diagnosing it was challenging. And that was sort of my second reflection on this case. A lot of logistical things didn't go super smoothly. We didn't have enough CSF the first time around. She didn't look like she was getting any TB in her sputum. And then when we needed anesthesia to get processes done, things were happening very slowly. What did turn out to be sort of a fascinating and very helpful aspect of this case was the dramatic evolution. 1 second, her lungs are clear. The next second, miliary processes have blossomed on CT imaging. We've got new embolic shower phenomenon. And from having no TB in her smear, all of a sudden she is having TB growing very quickly, easily stainable in her AFB smear from her sputum. And so it really actually was fascinating to watch this go down in real time because she really was almost two different patients at the start and at the end of this case.
Wow, thank you for sharing that, Cyrus. So going back to Natasha, would you like to maybe give us 2 or 3 teaching points of this session?
Yes, let me unmute here. So a couple of quick teaching points. So my first teaching point, the first teaching point I will have is fairly TB specific. As Cyrus says, it is extremely difficult to diagnose TB sometimes, especially TB meningitis. And so I would maintain a high index of suspicion for TB always in patients who are older, medically frail, and have the right comorbidities and the right travel history, especially people who have emigrated from an endemic area, because those are really the people in whom we see reactivation TB, and often with unusual and subtle presentations. I have seen so many humbling cases of TB in older immunocompromised patients as reactivation that I will always carry them with me as sort of lessons and as masterclasses in TB. The second thing I would like to highlight is the team correctly and patiently repeated tests when indicated. If your tests are not giving you an answer and the patient is getting worse, you have to consider repeating them. In this case, diagnosing this patient required a repeat LP and a repeat biopsy, and probably I'm not going to, and a repeat sputum culture, and I will not guess how many times blood cultures were sent during this hospital stay, but I anticipate it was many. That is correct. This patient was getting worse. We did not know what was going on. It makes sense to focus in on the areas that are most likely to yield a diagnosis, such as the LP, such as the biopsy. Tissue is always the issue, and to repeat those tests when clinically indicated. My third point, I think, is to consider using, if you can, unbiased diagnostics. The advantage of unbiased diagnostics, such as metagenomic sequencing, is that they do not require the person ordering them to have thought of the diagnosis. In a sense, most tests, like a cryptococcal antigen, are like asking the world, it's like the game Go Fish. It's like asking the world, does my patient have a red fish? Metagenomics is the only test that asks, does this patient have any fish, and which fish they are. It's a bit of a tortured metaphor, but I think in a case where you truly don't know what's going on, it's great to be able to ask a question, which is, what pathogens can we detect in the sample at all? So I think those would be my 3 points. TB is humbling, repeat tests, consider unbiased diagnostics.
Thank you so much. What an amazing case. This was an absolute masterclass. So thank you, Natasha. Thank you, Cyrus. We have reached to the end of our session. So thank you so much, everybody, for joining. And we will see you tomorrow for another amazing podcast episode. So have a great rest of your day. Thank you so much, everyone.
Thank you so much for joining.